Hi, all. Thank you for joining. We are just giving everyone a few more minutes to join us here, and then we will get started within the next 5 minutes. Hi, all. Thank you for joining us again. My name is Mariam Khan. I lead communications for Gradient Health Systems. I'm based in New York. Thank you for joining and for taking time out of your day to join us for this webinar. We really appreciate it. I will go through a few housekeeping items, and then I will turn it over to our moderator, Dr. Capicho, who will introduce our panelists and introduce this session as well. If you have any questions during the webinar, please use the Q&A feature to ask us. You should see that at the bottom of your screen. If you have any trouble with that, please just write it in the chat and let us know if you're having any technical difficulties. As you can see, this webinar is being recorded. We will send around a link to the recording following the webinar. If you don't get it for some reason, you can find it on our website under our training page, or you can also find it on our YouTube page under Gradient Health Systems. And then also, if you'd like to share any feedback or have any questions at the end of this webinar that weren't answered, or if you have any ideas for topics, please feel free to email us at customers@gradienthealth.org. And then lastly, we will have 4 polls during this webinar. You will see them pop up on your screen, and it's multiple choice answers. You just pick the answer that you would like to select, and the poll should disappear. We'll go through the answers through the presentation, but you will see something pop up on your screen during the presentation to answer and to engage with. And then finally, if there's anything you'd like to say, if you'd like to speak during the webinar, you can use the raise your hand feature at the bottom of your screen, and I will unmute your microphone. For now, I will turn it over to Dr. Papicho, who will get us started on this webinar. Thank you.
Thank you very much, Mariam. Am I audible?
Yes, you are. We can hear you.
Oh, thank you very much. I wish to welcome all our participants to today's webinar. We are discussing low flow anesthesia. We all know that anesthesia is a practice that really needs safety, and you need to take care of your patient and everyone during. Okay, I was getting some echo. Hope we're okay.
We're okay now.
Thank you. So everyone would like to practice anesthesia, and when giving general anesthesia, they would like to give low flow anesthesia. What is the principle behind low flow anesthesia? What's the physiology? What are the challenges and limitations of low flow anesthesia? To discuss that, we have 2 great presenters, Dr. Lina and Dr. Vicky. Dr. Victoria and Dr. Lina are great anesthesiologists working at KCMC in Tanzania. They'll be here with us today discussing this great topic. We welcome the first presenter, who's Dr. Lina. She's going to take the first part of this presentation. And after that, Dr. Victoria will take it up. As it was announced in the introduction by Mariam, try as much as you can to be active by participating in the polls, in the question that are going to be asked, or asking question whenever things are not clear with you. Dr. Lina, you are welcome.
Thank you. Greeting everyone. As I was introduced, my name is Lina Joe, a resident in anesthesiology and critical care program based at KSMC University. So I will go through the introduction of low flow anesthesia on this webinar part. Next. So before starting, I would like to know the point in how, which of the following, if you have an idea of low flow anesthesia, so you can answer which of the following is, what do you think, which of the following is the requirements for delivery of safe low flow anesthesia? So if you have an answer, you can just click on the poll 1 and give your opinion on the requested question. Which of the following do you think is the requirement of delivery safe low flow anesthesia? So I see one response says E, that's all of the above. Another one, response E. So another one says E. So I see most of respondents respond that all of the above are requirements for delivery of safe low flow anesthesia, that is end-tidal gas analysis, accurate vaporizer, closed non-linking breathing system, carbon dioxide absorber, together with accurate vaporizer. Okay, so it's just 77% of respondents know the answer. Next, please. So another question is concerning low flow anesthesia. Which of the following statements do you think is correct? So you can also respond this question in your chat parts. What do you think is the correct statement concerning the low flow anesthesia? We have fresh gas flow of 8 liters per minute. Low flow gas is not possible with halogen. Pressurized air is required. Low flow is contraindicated in children. And fresh gas flow of 250 mL per minute constitutes metabolic flow rates. So which one do you think is the correct statement? So 41% say the correct statement is fresh gas flow of 250 mL per minute constitutes metabolic flow rates. And another 22% says that fresh gas flow of 8 liters per minute constitutes the low flow anesthesia. So we'll see between the flow rate of 8 liters per minute and 250 mL per minute, which one is the correct answer? Next, please. So, introduction-wise, ever since the evolution of anesthetic technique from era of ether, using of open drop method, and the concept of reusing the anesthetic agent in the exhale gas gained significant attention. But after development of modern anesthetic machine that has also monitoring on gas analysis and the advanced vaporizers and introduction of potent volatile like desflurane with minimal uptake were some of the breakthrough encouraging low flow anesthesia. And due to the problem of environmental pollution, due to our gas or anesthetic gases during present day practice, mandates every anesthesia provider to take the effort and to have a knowledge on low flow anesthesia so to reduce the burden. Next, please. So before we, so there's this shows evolution of low flow anesthesia from the potassium hydroxide as carbon dioxide absorber to the introduction of low flow anesthesia by Mr. Foldes. So the Brian, we know, is the one that's introduced the SACO system. Next, please. So there was a survey that was done in India that was assessing the use of low flow anesthesia and the choice of inhalational anesthetic agents among anesthesiologists, and showed that 73.8% practices this technique. They practice low flow anesthesia at the rate of 0.5 to 1 liter per minute. So that is the low flow rate that is used more in anesthesiologists in India through this survey. So it shows that there is high prevalence in practicing the low flow anesthesia technique. Next, please. So low flow anesthesia is utilization of low flow than usual fresh gas flow. That is the rates of less than 1 liter per minute during anesthesia. So when you are using a rates of 0.5 to 1 liter per minute, that is the one we term as low flow. And when you go to 0.25 to 0.5 liter per minute, it is the minimal flow, and the metabolic flow is 300 mils per minute, and other articles suggest that is 250 mils per minute. So the one who answered that the metabolic flow is 250 mils per minute were correct. So the low flow has to be less than 1 liter per minute, not 8 liter per minute. That's some of respondents responded. Next, please. So the this by definition, you can say in a simple language that this is just a technique that the 50% of expired gas is recycled back to the patients, returned back to the patient after carbon dioxide or removal of carbon dioxide. So just the amount that is expired, the only 50%, when the 50% of expired gases after removal of carbon dioxide is returned back to the patient, that is when we term it as low flow anesthesia. Or another simple way you can just say is a technique of anesthetic management, which just use reduced fresh gas flow administer and control via the breathing system. Next. So this is useful after the development of the modern anesthesia machine, the gas analyzer monitor, the vaporizer, advanced vaporizers, and also the introduction of the potent volatile agents that has minimal uptake. So this is another table that just shows the classification or categories of fresh gas flow. That's from the medium flow of 1.2, and the low flow starts from the flow rates of less than 1, and metabolic one is about 250 mils per minute. Next, please. So you can see the graph that shows that in the beginning of inhalation or anesthetic administration, the fresh gas mixture with a given composition is been delivered. Then the uptake of agent into the body occurs per physical characteristic of which agent. It depends on solubility and also factors such as solubility and metabolism. And in closed circuits, the exhaled mixture in inspired gases remains. There's some point that will remain constant despite the flow. And if you have started with high flow or low flow, but there is a point where all gases will remain at the plateau level. Next, please. And the common agents that are used are isoflurane, desflurane, and sevoflurane, but desflurane has been reported to be the common gas used worldwide. So the consideration for delivery a safe, low fresh gas flow is oxygen delivery. So we are using a minimal flow rate, but you have to make sure that the oxygen that is delivered is enough for metabolic activities. And also you have to make sure that to deliver adequate oxygen, The circuit also has to be non-leak circuits, and also the uptake of anesthetic gases to reach the required minimum alveolar concentration so as to prevent the surgical response, because you can use low flow anesthesia technique and you can find that your patient doesn't reach the required mark for them to prevent response to surgical stimulus, and also the risk of hypoxia. So you have to make sure that the oxygen is well delivered and meets the metabolism requirements, and also the minimum alveolar concentration has been reached for preventing your patients to response from the surgical stimuli. Next, please. So this is just another chart shows the consideration that the breathing system must be sufficient, tight with no leak, so as to deliver adequate or required oxygen and gases. And also the anesthesia machine must allow setting to the lowest fresh gas flow, and vaporizer should allow dosing of anesthetic gas sufficient accurate in low flow range while you are monitoring your mark. And also you have to be monitoring your delivered gases like oxygen, carbon dioxide, and the volatile gases that are taken by the patient, so as to prevent harm and other risks that can be due to the complication I said previously. Next, please. So the flow meter that's calibrated to low flow as low as 50 meters per minute is one of requirements. A leak-proof breathing system and airway devices that like CAF DTT has to be tested and to prevent the leakage. And also you have to be having a monitor that can analyze and do a gas monitoring system, and also vaporizers which can deliver high concentration and also can calibrated accurate to deliver low flow. And also circuits should have minimal diameter or internal volume to reduce or to minimize reserve volume, and without forgetting the carbon dioxide absorber that is not exhausted, that can help to remove carbon dioxide, because remember in low flow anesthesia the expired 50% of expired gases is returned to the patients. So you have to make sure that your carbon dioxide absorber is working well to prevent hypercapnia and other risk of acidosis. Next, please. So as I said before, it is essential when managing low flow anesthesia to ensure that the oxygen delivery meets the patient's metabolic needs when using low flow gas anesthesia technique. So the oxygen supply must not drop below the physiological demand. So you have to make sure that to prevent harm to the patient and also to alter the physiological demand in the patient. And the mark has to be achieved so as to prevent your patients from movements in response to surgical stimuli. And use of potent anesthetic agents that can achieve the mark in low flow anesthesia technique. Next, please. Next slide. So we know I said before that they introduced this technique due to to prevention of environmental factor or pollution. And this is the study that was done to assess that it was assessing the causes of all things that contribute to environmental pollution, and it has been shown that 1% is contributed by inhaled anesthetic or by gases that we use in anesthesia. And one of the factors that's used to minimize the pollution and waste strategy was introduction of low flow anesthesia and other technique like using the advanced scavenging system and other limits of volatile that were harmful to the environment. So the introduction of low flow anesthesia is not only safe to the patients or safe to providers, but also it is safe practice for environment. Next slide, please. So how anesthesia cycle breathing system work? Can you go to the next slide to see the slide which shows pictures? Thank you. So as you can see in figure 1, this is just this is the picture shows the cycle breathing system that shows it has the system that has 2 unidirectional valves and tubing, and also this one is the patient, and also there's reservoir bag and APL valve. This shows that when the patient expires, the inspiratory valve is closed to prevent the backflow. It's closed to prevent the backflow of the gas. So the expiratory valve will open to allow the forward movement of exhaled gases into the reservoir bag that will begin to fill, and also the gas will go to carbon dioxide absorber for starting clearing carbon dioxide or removing the carbon dioxide from expired gas to make it well for rebreathed. And in figure 2, you can see during inspiration of phase, the inspirator valve will open, allowing the fresh gas flow from the anesthesia machine to the patient, and the recycled gas, or the one that the patient expire with, removed that one has the carbon dioxide will join with fresh gas flow and will go to the patient, while expiratory valve will close to prevent gas loss or contamination. And the patients at that moment will receive a mixture of fresh gas and rebreathed anesthetic gas that is coming from canister. So toward the end of exhalation, the reservoir bag in figure 3, you can see will be full, but the excess exhaled gas will be vented or removed through the adjustable pressure limiting valve, the blue one, you can see. So as to prevent this, help to prevent and maintain the pressure control and prevent gas building up in the system, so as to prevent complication like barotrauma or von trauma. So the major thing here is, or the main requirement here is carbon dioxide absorber that has not to be exhausted, so as to help to remove the carbon dioxide that is coming from exhaled gas that the patient has been expired, because some of the amounts will be inspired again during inspiratory phase. Next, please. So how do we achieve low flow anesthesia technique? We have different phase, that is initial phase, that is initiation of low flow anesthesia. And also we have maintenance phase of low flow anesthesia. And also this is just the initial phase. The objective here is just to achieve the alveolar concentration of anesthetic agents that is adequate for producing the surgical anesthesia. And there are different methods that can be used during this initial phase. That can be use of high flow from the beginning. You can start with using high flow from the beginning, and or you can just use to fill your circuits before and then connect to the patient, or you can just do injection of volatile, or you can just achieve by using the mixture with other drugs like opioid or hypnotic drugs. So the aim here is just to achieve the alveolar concentration of anesthetic agents for adequate surgical anesthesia. And in maintenance phase, it just here you have to just to maintain a steady state concentration of anesthetic agents needs to be maintained with flow rates of. So here is when you start practice your low flow anesthesia technique. So the rate here, or the flow rate, here has to be at least 1 liter per minute or less. Depends on what you want to practice. Either it's low flow, minimal, or metabolic. But remember that the oxygen uptake has to remain constant, at least 200 to 50 ml per minute to be safe to the patient for metabolism. And during this termination phase, it can take long to recover a patient from low flow because of long-term constants. So if we want to achieve the quick recovery of anesthesia, of a quick recovery in this phase, you can just switch back to high flow so as to wash out the anesthetic agent. Or some recommend the use of activated charcoal to remove the potent vapors by absorption. This can help to facilitate the rapid. So it's a stepwise process when you put your patients, or you want to put your patients on low flow anesthesia. Next, please. So there's a study that was done at Muhimbili National Hospital and Muhimbili Orthopedic Institute. That the objective was to assess how often low flow anesthesia is practiced, and they explore more on the factors that influence in volatile agent choice among anesthesia provider. And it showed that only 27% of providers routine practice the low flow anesthesia. So just a large amount of percentage of people are not practicing low flow anesthesia. This can be maybe due to limited access to modern anesthesia workshop or insufficient training and awareness about proper low flow implementation. So there is also lack of maybe adequate monitoring facilities, advanced workstation, and proper training is needed to highlight these things and this practice, because it has a positive impact both to our patients and also environmental wise. Next, please. So from what I have presented, which of the following do you think is a requirement for delivery of safe low flow anesthesia? So the question was all of the above, like end-tidal gas analysis is required to measure amount of gases that you're giving to your patients, amount of gases that is expired, and also accurate vaporizers that will be able to just provide or produce the minimal concentration that is required, and your closed in and leaking breathing system, so as to achieve the adequate fresh gas flow that has to be going to the patient, and carbon dioxide absorber that has not to be exhausted, so as to be able to absorb or remove carbon dioxide from expired gas before going back to the patient. Next, please. So regarding the question that's concerning low flow anesthesia, which of the following statements is true? The fresh gas flow of 250 ml per minute constitute to metabolic flow rates. So I see 20% of the patients who said that fresh gas flow of 8 liters per minute constitutes low flow anesthesia was not correct, because the fresh gas flow has to be from 1 liter and below. Thank you. So I would like to handle this to Dr. Victoria to continue the rest of presentation.
Thank you very much, Dr. Lina, for that wonderful introductory presentation on low flow anesthesia. Now we'll continue with Dr. Victoria, who's going to take us in another part of the presentation to discover more about low flow anesthesia. Dr. Victoria, you're welcome.
Thank you, Papichi. Thank you. Am I audible? I don't know if
yes, you are.
I am audible. Okay. So thank you, Dr. Lina, for taking us through the pharmacology and the physiology of low flow anesthesia. Now I will take you through the practical part of the low flow anesthesia. Can I get the slides to next slide, please? Next slide.
Are you seeing the poll slide?
I'm still seeing the poll slide.
Which side? Sorry.
Poll 3. Mariam.
Are you
Hi,
seeing the
Mariam.
slides move forward?
Uh,
There might be a delay.
okay. Yes, they are moving. Yes. So, the previous slide?
We started with 2 polls. Are you seeing these?
Okay.
Are we good at poll 3, just to make sure?
Next. Yes, we're on poll 3. Next
Okay.
slide. Next. Okay. Okay, so as Dr. Lina had mentioned, presented, we had started with the pharmacology and the physiology of low-flow anesthesia. Now take you through the practicality of low-flow anesthesia. How now do we do the low-flow anesthesia? So usually you would start with the initial high-flow phase, so as to saturate the system. For instance, you can start with 6 liters per minute for 5 minutes with a higher than target concentration on the vaporizer. The aim is to be able to saturate the of the anesthetic agent, and the patient is now on the maintenance phase. We'll see in the next slide how to do the initial high flow phase so as to saturate the system. After you have saturated the system, then you can transition to low flow settings, for instance, 0.5 or 1 liter per minute. During maintenance, you can change the vaporizer settings based on the end tidal anesthetic agent concentration. So if the anesthetic agent concentration is, let's say, your mark is 0.7, you may want to increase the vaporizer setting, or if it is more than 1.3, you might want to using the vaporizer settings will largely be dependent on the end tidal anesthetic agent concentration. If you want to rapidly alter the mark, let's say you want to increase it, you want to increase the mark, you will increase the fresh gas flow to 4 liters per minute for at least 2 minutes, and then you can return back to your low fresh gas flow. And at the end of the case, you can turn the vaporizer setting to 0 when they are doing skin closure. And once the surgeon has started dressing, you can increase fresh gas flow to 4 to 10 liters per minute with the aim of washing out the anesthetic agent to wake up the patient. Next, please. So we'll start with the initiation of the low flow anesthesia. In the previous slide, we saw that we want to saturate the system, the system as the first step. Our aim is to achieve 1.3 mark for the anesthetic agent and to achieve better denitrogenation. So we understand that the factors that build up the alveolar concentration, there are a number of factors that are building up the alveolar concentration. On the right side of your screen, you'll see some of the factors. Number 1 being the breathing circuit volume, the rubber gas solubility, the set inspired concentration, the concentration effect, the alveolar ventilation, and the last factor is the uptake of the anesthetic gas by the blood, which include cardiac output, blood gas solubility, and alveolar venous gradient. So for this one, we will concentrate on the breathing circuit volume as one of the biggest factors that will affect the alveolar concentration. Next slide. So still in the first phase of the initial high flows, what methods do we have that can help us to achieve the desired gas and agent concentration? There are a number of them, but in this presentation, we'll focus only on three methods. The first one is the use of high flow for a short time with the aim of saturating the system. The other one will be pre-filling the circuits, and the last one will be the use of large doses of anesthetic agent. In this first method, where we use a high flow for a short time, our aim is to load that circuit. So what you'll do, you'll use high flows for a very short time. You can use, let's say, fresh gas flow of 4 to 6 liters per minute for around 10 minutes with either 40% of oxygen and 60% of nitrous oxide. The vaporizer settings in this method, if you're using sevoflurane, for instance, you set it between 2 to 2.5%. After 10 minutes, the expired mark of your drug will most likely be around 0.8. So with 0.8 mark of the anesthetic agent plus 0.6 mark of nitrous oxide, this is for those who are using nitrous oxide in the anesthetic agent, will be able to prevent reflex movement to skin incision, something that we are aiming to achieve. The next slide. Okay, so this slide is trying to explain the high one actually to start from where we go. The cases in low flow anesthesia. So one, we have seen, Dr. Lina has taken us through and we saw that the entire circuit, the total volume of the anesthetic circuit is around 6 liters, including the tubing, the ventilator bag, the soda lime canister, and the tidal volume of the patient. Now, our goal is to maintain a constant agent concentration in the 6 liters at the desired mark value. Now, if, let's say, fresh gas is introduced at a low flow of 1 liter per minute, it would literally take 6 minutes to replace the full 6 liter volume once. But Dr. Lina has explained to us about the pharmacology, that it takes at least 5 half-lives for an injected drug to decay to 0 concentration, or 5 doses to reach a steady state. So in that case, if we use the pharmacology of the injected drug, we assume that it will take 5 changes of all the gases in the circuit to reach a steady state. Now, initially we said if we did not have the concept of 5 half-lives, it would probably take 6 minutes to fill up the whole 6 liters if we are introducing a flow of 1 liter per minute. But now, because of the pharmacology, we'll need to have to truly hit it. If you wanna introduce you may take longer to achieve and adjust the agent levels. And for that matter, we are preferring to start with high flows for initiation of the low flow. And once we have achieved the steady state, then we can go to low flow. Next slide. So this slide still continues to explain the previous slide. Let's go to next slide, please. Yeah, so I said we have chosen 3 methods. The first, using high flows for a short time. The second method is pre-filling the circuit. So here, ideally, we are priming. It's like priming the circuit. We are pre-filling the circuit with high flow with the anesthetic agent before connecting the patient. The advantage of this method is that you attain the fast equilibrium. You attain equilibrium very fast, and it reduces the agent lag on induction. The other method is the use of large dose of anesthetic agent. In the first method, we said we are using dial up the vaporizer setting above the target. So So maybe instead of 2 for, let's say for sevoflurane, you may start with 4 liters per 4%. And then you can also combine with high fresh gas flow, and then you can drop the both the fresh gas flow and the vaporizer dial setting once the desired depth has been achieved. It is kind of similar to the first one, but here you are actually, the primary goal is to use large dose of the anesthetic agent. The disadvantage of this is that you can get hypoxia, and it also may lead to a deeper than intended anesthetic depth. And also it's important to remember that we should avoid it in the elderly and hemodynamically unstable patient, because you are now going to use large doses of anesthetic agents. FiO2 should be kept above around 30 to 40, because now we are seeing there is a danger of getting hypoxia, especially if you are using nitrous oxide at the same time. Next slide, please. Yeah, so we have seen the methods that we can use to initiate our low flow anesthesia. But do we have ways that we can shorten the initial phase? Yes, we do. We can shorten the initial phase by accelerating the process of denitrogenation and washing phase. Also by using inhalational agents, anesthetic agents with low blood solubility and low individual uptake like sevoflurane. We can also accelerate the anesthetic depth, like the third technique that we were discussing. And then also the other way, we can stepwise reduce the fresh gas flow rate. So maybe you are starting with 2 liters per minute after 5 minutes, and then 1 liter per minute after 10 minutes, and then 0.5 liters per minute after 15 minutes. That is if you intend to use 0.5 liters per minute. Next slide. Next slide, please. Okay, so we have initiated low flow. Our patient has a steady concentration of the anesthetic gas. They are deep enough. Now we are going to the maintenance phase. The aims during this so that the patient remains anesthetized, to facilitate minimal uptake of the anesthetic agent by the body, and also to prevent administration of hypoxic mixtures. And this is especially if you are using nitrous oxide as well. Next slide. So when you have reduced your fresh gas flow to 1 liter per minute, remember to increase 50% to avoid hypoxia. Your vaporizer settings, if you are using sevoflurane, would be around 3%, while if you're using isoflurane, it can go up to 2%. With these vaporizer settings, expiratory concentration of 0.7 to 0.8 mark of anesthetic agent can be maintained. So on the right side of your screen, just below the graph, you can see a simple example. If you are running, let's say, a total fresh gas flow of 1 liter per minute, in the old settings, you would set oxygen, the inspired oxygen concentration at 30%. Next, am I even audible?
Hi, Victoria. Are you still there?
I believe for connection dropped.
Sorry, I got disconnected. Can you hear me?
We can hear you now.
Okay. So in the previous slide, in the maintenance phase, we talked something about, about avoiding hypoxia. It's very important to make sure that we are able to monitor the FiO2. Because now we are on low flow and we know there's a risk of getting hypoxia, so we should be able to monitor the FiO2s from our anesthetic, either the anesthesia machine or the hour monitors. Next slide, please. Now, in the emergence phase, in the very first slide, as I was presenting, it showed that during the emergence phase, we would switch the vaporizer setting to 0 when they are starting to suture the skin, and then increase the flow of fresh gas by the time the dressing. Here we are seeing a graph. This graph is showing us how long it will take for the anesthetic gases to be washed out after the vaporizer have been closed after 2 hours. And so if you are using low flows, let's say you're at 1 liter per minute, it may take up to 15 minutes for the gases to start quickly being washed out, and then around 10 to 20 minutes you may be able to wake your patient up if you are using the low flow. Next slide, please. Okay, so here we are. So in the previous slides, we were talking with, we were assuming that we are using nitrous oxide as well. But understanding that majority of us are in settings that we do not use nitrous oxide, that's where this slide is coming. The principle would still be the same. The conduct of the low flow will still be the same. You start initially by saturating the system, start with high flows to saturate the system. And then once you have reached the steady state, you have achieved your mark, you can then go to low flows. And after now you see you're going to the emergence of anesthesia, then you can switch off your vaporizer and move to high flow so that you can wash out your anesthetic agent. So the principle remains the same. Here is just more details. Pre-medication and induction is routine. You would use your additive IV opioids for analgesia, initial high flow phase of 4 liters per minute with 1 liter per minute of oxygen and 3 liters per minute of air. So ideally we say the 4 liters per minute is high flow. So 1 liter per minute is oxygen, the rest is air. And the vaporizer setting can be 1 up to 1.1 times the mark in the end tidal gas. Next. Then the flow can be reduced to 0.5 liters per minute after 10 minutes. So you can put 0.3 liters per minute of oxygen and plus 0.2 liters per minute of air. Vaporizer settings, isoflurane can go up to 5%, while SIVO can go up to 5% and desflurane up to 8%. I don't think if anyone is using desflurane in Africa, but I know majority of us are using isoflurane and sevoflurane. The expiratory anesthetic agent in the range of 1 to 1.1 mark can be maintained with these vaporizer settings. Next. Yeah, so these are the arguments for and against the use of nitrous oxide. I'll just read them, but I understand that most of us are not using nitrous oxide. But just oxide, we know it has rapid washing and washout. It shortens the induction time, and it reduces the need of opioid and anesthetic agents. While unfortunately it has its cons, there is high initial uptake and minimal uptake in the later phases, making the flow control adjustment even more complicated. There are issues of greenhouse effect that are currently big concern with nitrous oxide. There's increased incidence of postoperative nausea and vomiting, and there is increased gaseous distension of bowels, cavities, and closed spaces. There are some effects like immunosuppression, bone marrow suppression. Next slide. Now, so after seeing the practicality of low flow anesthesia, how we are doing it, let's see the benefits of low flow anesthesia. Why should we want to use low flow anesthesia? There are a number of advantages. Starting with the physiological advantages, we see that it preserves heat and humidity of inspired gases, and as a result, it reduces water loss and maintains temperature. It improves mucociliary clearance, and as a result, it reduces accumulation of dried airway secretions. In terms of anesthetic agent consumption, it is true that setting it up can be very expensive, but in the long run, it is very economic as it reduces the anesthetic agent consumption. And significant savings in order of 60 to 75% regarding the volatile anesthetic agents. In the environment, we see that it reduces operating room pollution because the high flows that we are using are one of the causes of environmental pollution. It's one of the known causes of environmental pollution. So if you are able to use saving our environment. Ecologically, there are reduced emission of fluorocarbons, similar. Oh, so the first one was on the operating room pollution. The second one is the environmental pollution. So this is the ecological point. It reduces emission of fluorocarbons and nitrous oxide in the atmosphere, which damages the Earth's ozone layer. And also it reduces greenhouse effect due to the fluorocarbons and nitrous oxide. Next. Now, there are a number of safety considerations that have to be taken when you are using low flow anesthesia. We have seen in previous slides that there are concerns about hypoxia. So we should ensure that there is adequate oxygenation. And as I said, we should be able to monitor the FiO2. If you are using low flow, you must be able to monitor the FiO2, but also you must be able to monitor the ventilation of your patient. Monitor all parameters, but most importantly, we should be able to get the end-tidal carbon dioxide, because we see with the low flows, there are maybe risks of rebreathing. So it's important to be able to monitor the end-tidal carbon dioxide. And if you feel at any point that your patient is rebreathing a lot of carbon dioxide, it's important to switch to high flow so that you can wash out the carbon dioxide. Avoid the hypoxic mixtures, especially if you're using nitrous oxide. It's the role of anesthetic gases monitoring. And it is a question to some whether we need to have to monitor the gases. I think it's very important to be able to monitor the gases if you are using low flow anesthesia, because that's what is going to guide you on whether you need to increase your anesthetic concentration or to decrease the anesthetic concentration. And then again, not every patient or surgeries can be done for low flow anesthesia. We have to evaluate these patients. So example of patients that we should not use low flow anesthesia are patients with alcohol intoxication, because exhaled ethanol and acetone can accumulate in the circuit, which may later interfere with agent concentration readings and potentially worsen CNS depression. For DKA patients, these are patients that are already hyperventilating and acidotic. If your CO2 absorbent gets exhausted and rebreathing kicks in, you may worsen their acidosis. So these are some of the conditions that you would want to stay away from low flow anesthesia. Next slide. Now, it's not all good. There are some limitations of low flow anesthesia. It's not ideal for short-term anesthesia, especially if you're using with a face mask, because let's say the procedure is lasting maybe 10 minutes or 15 minutes or even 30 minutes. And you see, we had phases. We had a phase where we had high fresh gas flow, and then we went to low flows. It may not be very practical if you are going to, for a procedure that is going to take a very short time. For procedures, also with the same with procedures with imperfectly gas-tight airways, because you don't want leakages. If your equipment have high gas leakage, again, you may not be able to have adequate, you may not be able to practice low flow effectively. If you have inadequate monitoring, as we said, monitoring of oxygenation, monitoring of anesthetic gases, monitoring of carbon dioxide, it may not be, those may be one of the limitations of the low flow anesthesia. For patients who are uncompensated diabetic states and intoxicated with alcohol, they have carbon monoxide poisoning. Again, you cannot use low flow anesthesia because you may risk them, as explained in the previous slide. Next. Okay. So we have seen the advantages of low flow anesthesia. Now, let's look at the disadvantages of low flow anesthesia. So the lower flow rates and long time constants can lead to slower induction and emergence. This is because you're changing the gas levels slowly. Induction and emergence can be very sluggish. For example, if you want to wake your patient up quickly after, let's say they stopped the surgery unexpectedly, and you want to wake up your patient with high flows, let's say you're at 4 liters per minute, you can wash out that sevoflurane fast. But if you are at 1 liter per minute, you're really stuck waiting. Emergence can drag by 10 to 15 extra minutes. So that can be one of the disadvantages of low flow anesthesia. So continuous vigilance and frequent flow adjustment are required to avoid hypoxic mixtures and under or overdosage of anesthetic agent. This of low flow anesthesia is a technique that requires the anesthesia provider to be with the patient continuously and to be vigilant throughout, because there are a number of risks that can occur, as we have explained in the previous slides. Another disadvantage is, even though the second disadvantage, I don't look at it as a disadvantage, because I believe as anesthesia care providers, we are just supposed to be vigilant continuously. So somehow I feel like this is a good thing, that we have to be continuously vigilant for every patient. But then if you are doing low flow, I mean, you have to be extra vigilant. Another disadvantage is higher consumption of CO2 absorbents and risk of hypercarbia and CO2 rebreathing with frequent exhaustion of absorbers. Also, you'll get accumulation of unwanted gases. So because we know low flows don't flush out gases very well. So anything your patient exhale or leaks into the circuit will build up. So anything. So for instance, if you had a patient who was diabetic, and so ketones and every other thing can be accumulated in your circuits. Yeah, so that's one of the disadvantages. And again, the danger of hypoxia and hypercapnia with the low flows. Next slide, please. Now, as good as low flow is, and as good as we think it is, there are a number of challenges of practicing low flow anesthesia in our settings. I think Dr. Lina had shared a research that was done on the practice of low flow anesthesia in Tanzania. A number of challenges are there. One of them is lack of oxygen analyzers. We have seen a high risk of hypoxia. So the lack of oxygen analyzer is making it difficult to monitor the inspired oxygen concentration accurately. This is now a significant patient safety risk. It's not uncommon to have anesthesia machine leakages in low resource settings. Now, if there are leakages, it again the lack of gas analyzers in patient monitors is making it difficult to measure the mark, hindering the safe and effective titration of the anesthetic agents. And also, again, importantly, lack of training. We have a limited training staff members in low flow anesthesia, limiting our ability to practice. So these are the challenges that are making it difficult for majority of anesthesia care providers to practice low flow anesthesia in their settings. Maybe the reason why they make flow anesthesia in the settings. Next slide. So to conclude, when using low flow anesthesia, the changes in the gas concentration and subsequent anesthetic depth occur slowly, but it can be hastened by increasing the flow rates. It's important, it's mandatory that we monitor oxygen and carbon dioxide for these patients, their fraction of inspired oxygen and their tidal carbon dioxide. Anesthetic agent analysis and more technique.
Seems like we've lost Dr. Victoria. Dr. Victoria, are you still there as we are concluding?
Do you hear the?
You are breaking. I believe the network is gone bad on your side. Thank you very much, Dr. Victoria. As you are trying to reconnect back, meanwhile, I would ask Mariam to give us the poll that we should have started with on the second part of the presentation, so that our participant can give us the answer to these two questions. The first poll is to know which of the following is an advantage of low flow anesthesia. It has been made easy after going through the discussion with Dr. Victoria, so we can easily pick the correct answer. The first option being preservation, heat and humidity. conservation of oxygen, conservation of inhalational agents, reduction of environmental pollution, or all of the above. Which one is the advantage of low flow anesthesia? Okay, the second poll. Wonderful. This really means that teaching took place. Correct. Dr. Victoria, are you back? Okay, as we are waiting for Dr. Victoria, we can go to the second poll. Which of the following will limit the use of low flow anesthesia? Wow, this is a nice one. What is going to stop you from doing low flow anesthesia at your station? Is it short-term anesthesia with face mask? Procedures with imperfectly gas-tight airways? Equipment with high gas leakage? Inadequate monitoring, or all of the above? After wonderful discussion from the two presenters, what could be the reason why low flow anesthesia could be a limit technique to your institution? All of the above. And then few picked equipment with high gas leakage, and one participant picked short-term anesthesia with a face mask. As we are concluding on this presentation, maybe in the question and answer, I can ask Dr. Sweetbird to make a comment on the poll number 4. I would like to remind you that as the panelists for this discussion, we have Dr. Ndaba, who's an anesthesiologist in Zambia, and Dr. Sweetbird Ndebeya, who's also an anesthesiologist in Tanzania. So I would like them to make a comment on the last two polls so that we can know why the answers are all the above.
Hello, Papicho.
You are very clear, please go ahead.
Okay, thank you so much. And thank you so much for the wonderful presentation by the two presenters. This is a very complex discussion and relatively new to most anesthesia providers, especially across Africa. So it's very important that we even explore modern anesthesia practice and also learn how things are improving these days. Yeah, so zooming in on poll number 3, I'm glad that the response so far has been very good, which shows that I think learning has taken place. So for this particular, I think I'll handle this one, and maybe my colleague, Dr. Sweetbird, can handle the 4th poll. Yeah, so which of the following is an advantage of low flow anesthesia practice? So I think all of these were, I think, discussed by both presenters. So preservation of heat and humidity, I think this one is very, very clear. So because of low flow, because you're not pushing in high flows, so you are likely not to lose so much heat to the patient, as opposed if you're doing high flows or even high flows on an open system. So you are recycling part of the heat, you are conserving the heat using the breathing cycle system. Remember also that the cycle system, you also have the carbon dioxide absorber. The reactions that take place with the soda lime also help to produce some heat, which helps to make the patient comfortable during anesthesia. The oxygen conservation, yes, because if you're using cylinders, for instance, and low flows, you are unlikely to consume so much oxygen, and that would help you to prolong the amount of oxygen you have. Conservation of inhalation agent, remember you are recycling and you are using minimum flows, only what the patient needs. So you not consume as much as you would if you are using high flows, for instance. Reduction of environmental pollution, yes. Remember you are recycling. Whatever is exhaled from the patient, so there's less that is discharged into the environment. So the answer here is all of the above. Thank you so much, the moderator.
Thank you very much. Thank you very much, Dr. Ndaba. I'm gonna call upon Dr. Sweetbert. And then Dr. Sweetbert, there's also a question by Mike Hello on the question and the answer, where he would like to know about the level, I believe the level of CO2, what to do when the level of CO2 goes up, and then we are using low flow anesthesia. What measures can one take? Because you have to maintain the safety level of CO2 between 35 and 45 millimeter of mercury. Yes, Dr. Sweetbert.
So I will start. Actually, I was reading the questions. So the first one was the level of carbon dioxide. So I think we should not confuse these two things, FiO2 and end-tidal carbon dioxide. So end-tidal carbon dioxide, as I think Lynn explained well, that you need a very cold circuit, of course, with the adequate working soda lime, so that you can recycle the gas by absorbing carbon dioxide. So in the event, I think the question was if it's not really clear, because he has confused the FiO2 and the carbon dioxide. If the end-tidal carbon dioxide goes up, I think you needed to go back and ask yourself what are the possible causes, or unless if you are asking if you are inspiratory carbon dioxide goes up, which means maybe if when the soda lime is not working, you have two options: either you change the soda lime, or you increase the flow, which means you have to go out of the low flow, because if you are inspiring carbon dioxide for whatever reason, you have to make sure that it's taken care of. But it's really important to maintain the within the end-tidal carbon dioxide within the normal range, but also taking into account making sure that the patient does not inspire carbon dioxide. So the FiO2 it has nothing to do with the carbon dioxide level, unless you are discussing the flow itself. Also asking about the depth of anesthesia, yes, that's why we said. I think even Victoria emphasized on the importance of monitoring the mark, but also depth of anesthesia. You can play around with the adjustment you want to maintain, either increasing or even also decreasing the gas to maintain adequate anesthesia. Going back to the question which was the poll number 4, I understand there are so many limitations. There are so many limitations regarding low flow in our setting. Victoria mentioned some of them, including training and all of those. So all of these ones also you have to be very careful, including some of this one when you are thinking of low flow. If you don't have a monitoring capacity whereby you can monitor your FiO2, you can monitor the tide, can even monitor the gases, I think you should not think of it. If the equipment has got leakage whereby you cannot keep the gas running through the system, but also you should not think about the low flow because you need to be vigilant when doing low flow because as apart from the all other complication, hypoxia is somewhere at the corner waiting for you. So that's why you need a good monitoring system so that you should not get a problem. I think most of the things we explained well with Victoria. I don't want to waste much of your time, but yes, there are so many advantages when it comes to low flow. I think with the era of changing toward Sevon or other expensive drug, even with the limitations we have in our setting, but we should start thinking about it if you're not late because you save on drug, you save on oxygen. So there are so many things which you can solve, and apart from quality of anesthesia, you are giving all of those, but also the fund saving part of it when you go to the low flow. So let me stop there and take it back to the moderator unless there's something I've missed. Thank you very much once again.
Thank you very much, Dr. Sweetbird. Before we close it, there's one last question in the Q&A, somehow addressed to Dr. Lina. Dr. Lina, would you be in this situation to get this question? When choosing inhalational anesthesia, stability was mentioned in the first presentation as a factor. How does it affect emergent children?
Okay. Thank you. So the question is, when choosing inhalational anesthesia, stability was mentioned in the first presentation as a factor. How does it affect an agent chosen? So one of the important factor is the potence of inhalation agent. So when you are using the inhalation agent that has good stability on environmental factors like temperature, and the inhalation agent is potent, it helps in achieving, it just facilitates in achieving the initial phase and maintain the steady concentration in maintenance phase. So it will just help in using or preventing using large amount of inhalation agent or large amount of concentration.
Thank you very much, Dr. Lina, for that brilliant explanation. I can see on the Q&A, there's no more question. Yeah, I think we've answered all the questions that were pending. At this point, I'm going to call upon Magdalena to give the final remarks before we end the webinar.
I would like to thank Dr. Lina and Dr. Victoria for the wonderful presentation. I also like to thank our moderator, Dr. Papicho, and also thank our panelists. Thank you so much for organizing the webinar. I would also like to very, very much thank our participants. Thank you for making the webinar lively. We don't take it for granted. For any questions, for any feedback, please get back to us on customers@gradienthealth.org and look out for the next webinar. For any interests with our machines, please check out our our website, Gradient Health Systems. Just Google it and you will get it. Then in case you're using our machines and you have any feedback, good. In case you need any technical assistance, in case you are having issues with usage, in case you want to purchase any spare parts, you need any help, please don't be hesitant. Reach out to us. We are always here to assist in any way. Write to us, customers at gradienthealth.org. Thank you so much and see you soon. Bye.
Bye.
Thank you. Bye-bye.
Yeah,
Bye.